Hey everyone, welcome to this visual analysis. So imagine this for a second. You're a doctor, right? It's a totally chaotic emergency room and a patient comes in coughing, feverish, and just really struggling to breathe. What do? Well, today we're diving into exactly that by exploring the CURB-65 scale, a true gold standard around the world for community-acquired pneumonia triage. Okay, let's jump right in and decode how this actually works.
Because here's the ultimate high-stakes clinical dilemma every single doctor faces when that coughing patient arrives. Do you send them home with a simple prescription? Do you admit them to a standard hospital ward? Or do you rush them straight into the intensive care unit? Make the wrong choice here, and the consequences can literally be fatal. This is the exact problem CURB-65 was designed to solve. To master this, here is our quick clinical detective roadmap. We'll start with the clinical problem, then break down the 5 vital parameters of CURB-65. After that, we'll cover risk assessment, touch on a variation called CRB-65, along with some of its limitations, and finally, test yourselves with a few practical cases.
All right, Section 1, the clinical problem. Let's get some historical context on why we even need a scoring system for pneumonia in the first place.
So the history behind this tool is actually fascinating. Before 2003, doctors relied on something called the PSI, or Pneumonia Severity Index. And look, it was highly accurate, but it had over 20 parameters. I mean, imagine trying to calculate that in a frantic ER. It was just way too bulky. So the British Thoracic Society stepped in and introduced CURB-65. They brilliantly streamlined the whole thing down to just 5 essential parameters to predict a patient's 30-day mortality risk. Boom, emergency doctors finally had the lightning-fast standard they so desperately needed. Moving right along to Section 2, CURB-65 and its 5 vital parameters. Let's break down the actual pathophysiology behind each one of these letters.
We start with C for confusion. We're talking about mental disorientation here, like a patient who suddenly, doesn't know where they are. In clinical terms, that's an abbreviated mental test score of less than 8. But why does pneumonia actually cause this? Well, inflamed lungs impair gas exchange, which leads to hypoxia. The brain is literally starving for oxygen. You combine that with systemic toxins from a severe infection causing sepsis-related encephalopathy, and you get this really dangerous drop in cognitive function. That right there earns 1 point. Next up is U for urea. This parameter is super interesting because it shows just how interconnected our organs really are. A blood urea nitrogen level above 7 millimoles per liter gets another point. Why? Well, severe pneumonia causes massive fluid shifts. Blood vessels become permeable, fluid leaks out, plus the patient is sweating out water from their fever. This all leads to low blood volume, or relative hypovolemia. So the kidneys aren't getting enough blood flow, which triggers pre-renal failure, and toxic urea starts building up in the blood. It's a massive red flag that the infection is exhausting the whole body.
Then we've got R for respiratory rate. Think about this threshold for a second. 30 or more breaths per minute. When lung tissue is inflamed and filled with pneumonia, the lungs lose their elasticity, their compliance. The actual area available for oxygen exchange shrinks way down, so the body tries to compensate by breathing faster. But trying to keep up a rate of 30 or more, that is incredibly exhausting. It signals a severe risk that the breathing muscles are just going to give out entirely, leading to rapid respiratory arrest. So that's a critical 1 point.
Moving to B for blood pressure. Here we're looking for strict, really dangerous drops, a systolic pressure of less than 90 or a diastolic of 60 or below. These numbers are terrifying because they signal the onset of septic shock. Bacterial toxins cause massive vasodilation, the blood vessels widen out way too much, blood pressure plummets, and vital organs like the heart and brain stop getting the blood they need. If a doctor sees this, that patient needs immediate IV fluids and vasopressors. That's another 1 point.
Finally, we wrap up the acronym with 65, which simply stands for age 65 or older. Why is age an automatic risk factor? It's mostly due to immunosenescence, the natural weakening of the immune system as we get older. Plus, older patients often have underlying conditions like heart failure. But the scariest part? Severe pneumonia in elderly patients often hides behind atypical or completely silent symptoms. They might not even have a high fever, maybe just general weakness. So age alone gives us that final potential point.
Okay, Section 3, Risk Assessment and Treatment. Let's transition over and see how we take these individual points and turn them into a definitive, life-saving action plan.
Let's look at the ultimate clinical matrix. Let's tally it up a score of 0 or 1. The 30-day mortality risk is really low, under 3.2%. You can comfortably treat that patient at home with oral macrolides. A score of 2 bumps the risk up to about 9%, so they definitely need hospital admission to a standard ward for observation and IV antibiotics. But a score of 3, 4, or 5, mortality risk absolutely skyrockets, potentially reaching 57%. These patients need immediate broad-spectrum IV antibiotics and multidisciplinary intervention right in the ICU. The score literally dictates the survival strategy.
Section 4. CURB-65 and scale limitations. Look, no tool is perfect, so let's talk about some real-world adaptations and the dangerous blind spots every single practitioner absolutely must memorize.
First, let's talk about adaptations. When we compare standard CURB-65 directly with CURB-65, you might notice something missing. Yep, the U for urea is gone. Why do this? Well, if you're a paramedic in the back of an ambulance or a doctor in a remote rural clinic, you just don't have time to wait around for lab results. CURB-65 drops the urea parameter entirely, creating a 4-point scale that relies 100% on clinical observations you can make in seconds. It's a total game changer for rapid triage.
But we have to clearly warn you about what this scale misses. First off, it completely ignores comorbidities. A young patient with a score of 0 might look totally fine on paper, but if they have advanced HIV or severe heart failure, sending them home could be a fatal mistake. Second, it doesn't include blood oxygen saturation data, or SpO2. A patient could be breathing at a normal rate but have critically low oxygen levels. And finally, it doesn't account for severe multilobar infiltrates on an X-ray. In those tricky, complex cases, doctors really have to fall back on the older, more detailed PSI scale.
And finally, Section 5, Practical Cases. It is time to put our clinical detective skills to the ultimate test with a couple of real-world patient scenarios. You ready?
Here's case number 1. A 70-year-old patient comes in with a cough and a fever. Let's check the vitals. They are fully conscious and clear-headed. Respiratory rate is 24. Blood pressure is rock solid at 120/80, and the lab work shows urea at 6.0. Take a quick mental note of all those numbers.
Okay, let's walk through the math together. Confusion? Nope, that's 0 points. Urea is 6.0, which is below the 7 threshold, so 0 points. Respiratory rate is 24, under 30, so 0 points. Blood pressure is totally normal, 0 points. Age? Well, the patient is 70, which is over 65. That gets exactly 1 point. So, with a total score of 1, we can confidently conclude this is a low-risk patient who can be treated safely at home with some oral antibiotics. Easy enough, right?
Now, let's look at a much more terrifying scenario. Case 2. A 55-year-old patient arrives via ambulance. The family says he's been deeply confused and delirious. He's breathing really heavily, 32 breaths per minute. His blood pressure is critically hypotensive, sitting at 85/55. And the labs just came back with a urea level of 9.0. Let's run these numbers.
All right, let's tally this up fast. Confused? Yes, 1 point. Urea over 7? Yes, it's 9.0, that's 1 point. Respiratory rate over 30? It's 32, so 1 point. Blood pressure under 90 systolic? Yes, it's 85, another point. Age is 55, so 0 points there. That gives us a total of 4 critical points. This brilliantly illustrates a textbook high-risk scenario. This patient requires immediate multidisciplinary ICU intervention and a full septic shock protocol right now. You know, the absolute most crucial takeaway from all of this is summed up perfectly by this golden rule. No statistical tool, no matter how refined or historically proven, can ever replace your own sharp clinical judgment and intuition on the ward. CURB-65 is an absolutely phenomenal guide, but it's just that. It's a guide. You always treat the whole patient, not just a number on a chart.
And that brings us to the end of our visual explainer. We've decoded the 5 parameters, mastered the risk matrix, and really put our detective skills to the test today. So I'm going to leave you with this final, provocative thought. What score will your next patient get? Keep practicing with these concepts, apply this new mastery in your clinical rotations, and most importantly, use it to save lives. Thanks so much for joining us for this analysis today, and keep learning.